Hi, I'm Stephanie Brooks, an equine veterinarian, and today we'll be talking more about equine herpes virus 1. In this video, we will be discussing the non-respiratory manifestations of the disease, including abortion, perinatal disease, and neurologic signs. So what are the clinical presentations of EHV1? Starting with abortion, it is one of the most common infectious causes of abortions in horses. It most commonly occurs in the last 4 months of gestation. The mare typically remains healthy and the abortion occurs unexpectedly. You can have abortion storms, but there are no long-term effects of abortion on reproductive performance of the mares, and they typically produce normal foals in subsequent pregnancies. Perinatal disease in foals has a few different manifestations. Firstly, the foals can be stillborn, where they appear fresh and their membranes are still attached. Secondly, you can have a weak foal that's unable to stand. And finally, you can have a foal that is born apparently normal but develops EHV1-associated respiratory disease within the first 24 hours of life. These foals usually become depressed, they fail to nurse, they're febrile, have an increased respiratory rate and die within the first few days. If they do manage to survive longer, they develop a severe pneumonia complicated by secondary bacterial infections within the first 2 weeks of age. It is important to differentiate these foals from those affected by bacterial infections alone. Finally, we'll discuss neurological disease, known as equine herpes virus myeloencephalopathy, or EHM. It can occur singly or as an outbreak. The signs appear suddenly and may or may not be preceded by respiratory disease. These signs include weakness in hind limbs, a wobbly gait with stumbling, and reluctance to move. In severe cases, they can develop tail paralysis, dribble urine due to bladder paralysis, and can become recumbent if unable to stand. Prognosis depends on the severity of the disease. There is a good prognosis for non-recumbent horses that are treated with appropriate care. However, a poor prognosis for those that do become recumbent. Most mildly to moderately affected horses return to a level of athletic performance comparable with that prior to EHM within 1 year of recovery. Now on to the development and life cycle of the virus. The virus initially infects the cells lining the respiratory tract of the nasal passages. It has a unique feature of being able to establish latency, whereby the virus effectively hides from the immune system and does not cause any clinical signs or shed. Infected animals are able to undergo multiple cycles of latency and reactivation. Importantly, the virus can also spread to other organs, causing the clinical signs we just discussed. These non-respiratory signs occur when infected cells are carried in the blood to vessels in the uterus or the central nervous system. Once this has occurred, the virus may reactivate locally within the uterus or the central nervous system, leading to abortion or neurologic disease without nasal shedding of the virus. The neurologic signs usually develop 4 to 9 days after the initial peak of infection, or 1 to 4 days after resolution of the second peak of infection. Abortion can occur from 2 weeks to a few months following exposure to EHV1. So how do we diagnose actively infected horses? For abortion and neonatal disease, diagnosis is based on history, clinical presentation, and detection of EHV1 in fetal or neonatal tissues. In live foals, infection can be confirmed by detection of the virus in nasal secretions and blood. In neurologic disease, confirmation of EHV1 involvement is often challenging. This is because nasal swabs are often negative due to reactivation locally of the disease or the neurologic signs occurring later in the progression of the disease, meaning they are no longer shedding. Diagnosis is therefore based on a combination of laboratory, epidemiological, and clinical data combined with exclusion of other causes of neurologic disease. So how do we treat this? A mare that aborted due to EHV1 infection typically remains healthy. Neonatal foals can be treated symptomatically, however most die. Therefore, euthanasia should be considered for neonates with confirmed EHV1 infection. Treatment has been attempted in cases of neurologic signs. This has a focus on reduction of inflammation associated with vasculitis. This is achieved with a combination of anti-inflammatory drugs and free radical scavengers. Antimicrobials are also used to reduce the chances of infection, especially if they need a urinary catheter. And supportive care includes intravenous fluids, tranquilizers, and parenteral nutrition. Vaccination is an important part of EHV management. It is not expected to provide 100% protection against disease. It will, however, minimize the levels of the virus shed by infected animals, limit the severity of the respiratory disease, and reduce the numbers of abortions. Vaccination schedules typically involve 2 initial doses given 3 to 4 weeks apart, followed by 6 to 12-month boosters. If wanting to prevent abortion, this typically requires the initial 3 doses to be scheduled so that at least the last one is delivered in mid-pregnancy, followed by annual boosters. None of the EHV1 vaccinations are currently marketed for prevention of EHV1-associated neurologic disease. In terms of the immune response, the duration of immunity following EHV1 infection is thought to be short, and reinfection can occur every 3 to 6 months. So what is the prevalence of EHV1 in New Zealand and Australia? In one study, approximately 70% of adult thoroughbreds greater than 2 years old tested positive. Only a very small proportion of those infections results in clinical disease, and the proportion of healthy horses actively shedding the disease is very low. Horses can become infected with EHV1 at any age, but most primary infections occur early in life, with or without clinical signs of respiratory disease. Foals can become infected before weaning, even in the presence of maternally derived antibodies, and this primary infection results in the establishment of lifelong latency. That's all for now. Thank you for watching, and I hope you found this video useful. Please feel free to reach out to myself or the NZERF if you have any further questions.